Hello and welcome back to the Holistically Well Podcast. I'm your host, Dr. Kayla Borchers, and today I am joined in person with Cassie Subler, which is so exciting. This is the first time I've had a guest in my office to record with because she is local. We live just down the road from each other. And so far, the guests that I have interviewed have been out of state. And so for anyone local to Midwest Ohio, Cassie is a local provider as well, and we are so excited to dive into all things birth today. So whether you are planning an unmedicated childbirth or planning on using pain medication or are open to all options, your voice matters, and we want you to walk away with the tools to feel empowered no matter what position you find yourself in, whether it is a birth center or a hospital, childbirth. We are going to be focusing on advocating for yourself, specifically in a labor and delivery unit, home births. Cassie has also experienced, she is a doula. She has also been a labor and delivery nurse. And so we are going to get her standpoint today on how to advocate for yourself in different settings, because I know so many women who want an unmedicated or more natural childbirth, but feel most comfortable in a hospital or birth center setting and don't feel comfortable going for a home birth right off the bat. And so we'll be talking through your different options today. Again, just to point the picture from the beginning, this is not to say one setting is beneficial over the other. That is something that you need to work through with your spouse and with your care team. But we are going to give you the tools to help navigate a hospital or birth center setting and how to do that in a very empowered and naturally minded way. So Cassie, thank you for joining us.
Yay, I'm so excited to be here. A little bit about myself.
Yeah.
So I have been a nurse for 6 years, 3.5 of those on a labor and delivery unit, which in college was definitely my dream job, is what I wanted to do. And as we talk through the episode, we'll talk through some of the things I really loved about being a labor and delivery nurse, and then some of the things I also didn't love. But that's where the bulk of my experience was. And that experience as a labor and delivery nurse inspired me to go on to become a doula. And then being in the holistic women's health space really inspired me then to go on also to become a fertility educator. So really passionate about all things women's health. I'm also a mama to 2 little boys, a 3-year-old and a 1-year-old. So loving life and loving to be able to support women in this space.
Absolutely. So Cassie, can you set the scene? What is really happening on a labor and delivery floor? So you've been on the front lines of hospital births. So can you paint the picture for our listeners on what it's like in a labor and delivery unit?
Yeah. So it's definitely interesting. So a little bit of what it's like from the nurse's perspective. So as I was thinking about this, it's a lot about policies and procedures, screens and routines, if I could kind of summarize it all into that. So to explain that, policies and procedures, so basically everything we do in the hospital setting as a nurse, there's a policy and there's a procedure for it. The goal with that is safety and high quality care. So a lot of times when people in this holistic birth space, they hear policies and procedures, they're like, they just want to control you. The hospital administration just wants to control you. No, that's not the idea behind it. But that can be kind of what happens unintentionally with when there is a policy or procedure in place. For example, a procedure that is pretty routine in the hospital setting is right when you get admitted, you get an IV put in your hand or your arm. And that's not an essential. You don't need an IV in your arm to have a baby. But it's a thing that we do as nurses, because it's a policy and it's a procedure. And the rationale, is for your safety, but it may be something that a person giving birth does not prefer. So that's the policies and procedures part of it. The screens and routines is a different thing. So screens, so as a labor and delivery nurse, their job, or the job of a labor and delivery nurse, is really primarily to monitor your baby's heart rate. So if you've ever given birth before, or you've seen anybody that's been giving birth, there's these little disc monitors that get put on their belly to measure contractions and then measure the baby's heart rate. That is like a big part of the labor and delivery nurse's job, is to manage those monitors and make sure that they're showing up on the screen, and then also to be looking at that screen and making sure that the baby's heart rate looks good, that there's nothing that's alarming about the baby's heart rate. And then also we have to document that into our database as nurses to kind of cover for making sure that we are looking at the baby's heart rate at least every 15 minutes. So every 15 minutes in the computer, as nurses, we're documenting what does baby's heart rate look like? What does baby's heart rate look like? Which is great. Again, safety is the goal. The goal is, as nurses, is to make sure that we are keeping close eye on the baby's heart rate so that we know that the stresses of labor aren't overtaxing the baby's heart. That's the screens part, and then routines. So there's some things that go, again, beyond just those policies and procedures, just routines about what goes on in different units. And I can't say what the routines are on every labor and delivery unit because every unit's going to have a different culture. So I worked at a more rural hospital, and so I worked labor and delivery and postpartum. So I got to see a little bit of everything. At your bigger hospitals, you're going to have units that are just a labor and delivery unit and just a postpartum unit. So people are more specialized into just labor or just postpartum.
Yes, where I gave birth in Columbus, I gave birth at the Ohio State University Wexner Medical Center for my first 3 children, and they were separate units, and that is pretty common unless you're in a rural hospital setting. Now, I will say I gave birth, like I said, to all 3 of my first babies with midwives, but at the hospital. And I was able to have intermittent monitoring. I was able to decline cervical checks if I did not feel they were needed. However, I will say with my first baby, this was also new to me. I thought that whatever they said I needed to do, I needed to do. Okay, it's time for a cervical check. And I was like, okay. I didn't push back or ask as many questions. And then as I started diving into more holistic women's health strategies, I realized, okay, some of these policies and procedures, to your point, are optional, even though they feel like they are required. So Cassie, what are some common hospital policies or routines that women might assume are required, but they're actually optional?
Yeah. Really everything is optional. So I don't think I mentioned this initially, but I teach childbirth education classes as well. And my really biggest thing that I talk about in my childbirth classes is that, every choice is yours and everything is truly optional. You can have a baby at home. So really anything that happens in the hospital truly is optional. But if we're, breaking it down, so I talked about the IV initially. So you're definitely going to want to discuss these things with your care provider before you're coming in labor so they know some of your preferences. But an IV is optional. Cervical checks are optional. Other things. Monitoring, they're going to want to be doing some sort of monitoring of your baby. And I think as mamas, most of us would want monitoring of our babies so we know that our baby's doing well as well. But like Kayla said, intermittent monitoring is an option. Typically, the routine in the hospital is going to be continuous monitoring with monitors on your belly that are strapped and then plugged into a computer. There's actually some really cool options nowadays that have some Bluetooth options so that instead of being attached to a monitor, you can have this continuous monitoring and still be mobile, which is really, really important. And then definitely staying in bed is definitely optional, and I would highly recommend against just laying in bed on your back during labor. Motion is lotion when it comes to birth. So as much movement or just changing in positions you can do is awesome. And then again, like epidurals are obviously optional as well. And there are a whole variety of pain relieving options. So that's some of them.
Yeah. So cervical checks. So to somebody listening who has never been offered one or doesn't know what that is, what is a cervical check and why would we choose to decline it at a given point in labor?
Yes. So when you're in labor, one of the big things, so when your uterus is contracting, what's actually happening is your uterus is your cervix, which is the very base of your uterus, is opening to allow baby to come through. Your contractions are helping to pull that cervix kind of away from the opening to let baby get through. So what a cervical check is your care team, so either your doctor, midwife, or a nurse, inserting 2 fingers into your vagina to feel that cervix to see how dilated it is, which is how open it's getting, and then how effaced it is, which is how thin it's getting. And then also looking at what station the baby's at, so how far down is that baby in your pelvis. So those big 3 things we're looking for. And the reason that we would do this as care providers would be to see, how labor is progressing. But those are the benefits. The risks of a cervical check, or that it can increase your risk of infection. That's probably one of the biggest things. And it's uncomfortable, and it really does not have a high predictive value. So by that, I mean, you can be 3 centimeters dilated, and then an hour later you can be 9 or 10 centimeters dilated. Or you can be 3 centimeters dilated and 3 weeks later still be 3 centimeters dilated, depending on where you are at in your pregnancy. So it's really not predictive of when labor is going to start or how quickly labor is going to progress. It really just kind of is a snapshot in time of how far dilated is my cervix at this moment.
That's so helpful. And just to give you guys like a personal anecdote here. So again, first pregnancy, like had no idea, just did whatever my provider kind of offered and asked about. Next pregnancy at 39 weeks, so they start offering cervical checks usually at your appointments 37 weeks and on. I declined them at 37 and 38 weeks, but at 39, I said, yes, let's check, because if you're at least 1 centimeter dilated, they can do a membrane sweep, and that can just help get things going if you're feeling like, okay, I am ready for this labor to start, whatever, whenever baby's ready. So it is a naturally minded tool to help potentially stimulate the start of labor. So that is why I accepted a cervical check then and did a membrane sweep. When you arrive at the hospital at triage, they will do a cervical check. And that one, I would say is probably not so optional.
Again, everything's optional, but that one makes the most sense, because if you're only a centimeter dilated, they're going to tell you to go home, which
Correct.
is awesome, which is you don't want to be in the hospital. If you're trying to avoid interventions, you don't want to be in the hospital longer than you need to be. So if you're 1 centimeter dilated, they're going to tell you, go home, go to the park, go for a walk, come back when things are more regular. Or, if you're 5 or 6 or 7 centimeters dilated, they're going to know, okay, this is the real deal. So that one's important.
So if you decline a cervical check when arriving to triage, though, because for my experience, they like to have that cervical check to know how dilated you are to then admit you.
Yes.
To your point, if you're only 1, but you feel like things are intense, but if you're only 1, they might send you home. Like, have you seen women decline a cervical check in triage, and what's the next step? Can they still be admitted? How do things work?
I've never seen it. They usually just do it. From my personal experience, this was just because things progressed quickly, but with my second son, I arrived in triage. The nurse asked me to get on my back to do a cervical check, and I was in transition, and I was like, I cannot sit on my back or lay on my back, and she's like, well, you can decline the cervical check if you want. I'm like, okay. Then she said she was going to get the midwife, and while she was gone, my son was born. So
amazing.
I did decline the cervical check, but that was because the baby was about to
be
born.
To push. Yeah.
Typically that's not what's happening.
Yeah. That is amazing. And so I'm glad we talked through that, because they have these policies and procedures in place for a reason. And so some of them, while yes, we can give pushback and some are optional, some are more like, okay, that makes sense from a decision-making standpoint. So my biggest question that I always ask myself, is this going to change what care you provide? In that state, yes, it's going to change whether they say, go home, you're not far enough in labor to be admitted, or like, yes, we are ready to admit you, and progress through the rest of labor here. So that's something to ask yourself. Other times I accepted a cervical check was then I would decline until I thought that I was at a point where I was ready to get in the tub to labor and push. And for the hospital I was at, their policy was that you had to be dilated to at least 6 in order for them to start filling up the tub for you to get in labor, because they didn't want it to slow down your labor if you got in too soon. And so for me, I was like, okay, I'm gonna labor up until I think I'm gonna be at least at a 6 or a 7 when they check. And then I was at like a 7 or an 8 when they checked. So I did that with my last 2 births. And then I also very much declined cervical checks when I had a premature rupture of membranes for my 3rd child, because to Cassie's point of infection, that is the greatest risk of infection, is when you're inserting something vaginally, inserting fingers vaginally, and you have this disruption in the barrier from the outside world and baby if that water is leaking. So just something else to keep in mind if you have premature rupture of membranes or if your water has broken, to be extra wary of extra cervical checks.
Yeah, which I didn't mention that before, of things that are optional. Getting your water broken is definitely optional. Typically, if your doctor or your midwife doesn't break your water, your water is typically going to break on its own when you're like 9 or 10 centimeters dilated. As those contractions really start to push baby out, typically it's going to, you're going to have your water break then. So that one's a really big one, because out of all the things that you can do in a labor and delivery unit, like you can't undo having your water broken. I mean, if you are having an induction and you start Pitocin or you start different medications, you can stop those medications, but you can't undo your water being broke. So I think sometimes care providers don't take it as seriously as they should, that like, okay, well, this decision you can't undo. So definitely it's an important decision to discuss the benefits and risks of before you go ahead with it.
Okay. So I had mentioned how I decide if I'm going to go forward with something or not. And it's, okay, is that going to change the next step in my labor journey? So what are other ways women can understand informed consent and their rights, and how to go about decision making when in labor and delivery?
Yeah. So it really comes to doing your research before, when you're pregnant, really researching what your preferences are, going, you can look up online, like a birth plan or your birth preferences, and really looking what your options are. One thing I explain in my class is that if you don't know what your options are, you don't really have any. If you go to a restaurant that you've never been to before and they don't have a menu, like you don't know what to order. So if you've never thought about, what are my options in the hospital? Like you're not going to know, and you're not going to feel like you can make choices, especially when you are in a labor, which is a very vulnerable time because you're uncomfortable, you're in pain, you're about to have a baby. So really doing your research, doing a childbirth class of some sort during your pregnancy is super important. So you and your husband and then maybe your doula are all on the same page of, this is what we want, these are our preferences, so that when you're in the moment, you're not having to think, well, what are the benefits and risks of all these things, because you've thought about it beforehand. But when you're in the moment, if something comes up that you aren't familiar with, really asking about the benefits, risks, and alternatives of any intervention. There's an acronym called BRAIN. So it goes through, again, benefits, risks, alternatives. What does your intuition say? So how does that feel? Like, what does your gut say? And then N stands for, what if we do nothing? So again, let's say it's a cervical check. So we talked about a little bit, but benefits are, it tells you how far dilated you are and what stations baby's at. Risks are infection and discomfort. Alternatives, the alternative is just to let your body kind of do its thing. Your intuition, again, that's going to be what does your mind say? What does your gut say about this decision? And then, like we said, what if we do nothing? What if we don't make this decision at this point and wait 15 minutes, wait 30 minutes?
That's great. I love that. And so you can always say, can we have a minute to decide, and ask the provider to go out and you and your spouse just talk amongst the two of you? Or to her point, ask about the risks, benefits, alternatives. What happens if we do nothing? I would write that alternative down, that brain phrase down, so that you and your spouse just have that front of mind when you are laboring. Because to her point, when you hit transition, like everything kind of goes out the window. Like, it can be really hard to communicate your preferences. And so to make sure your spouse is on the same page, or that can be the benefit of hiring a doula to be another voice in the room for you when you can't communicate for yourself. So just slow things down and give yourself a little bit more time to decide. And sometimes things just naturally work themselves out then. So with my third child, I mentioned the premature rupture of membranes. When I arrived to the hospital like 12 hours later, because I just got a good night's sleep first, I was like, we'll see if labor starts on its own. It didn't. And so when I got there, they, of course, confirmed that it was premature rupture of membranes. And then they recommended Pitocin. And I did not want to kick things off with Pitocin. I was like, let's start with nipple stimulation and see how that goes. And they're like, okay, we'll give it 2 hours and see if your body does anything. So sometimes just having the timeline and making sure it's an ample amount of time. Like, I knew significant increased risk of infection or issues did not happen until 48. Ideally, you're kind of giving birth within 24 hours, but we have cushion room. I could have gone to 48. And so anyways, giving yourself that time to work through things versus rushing into a decision. Because while yes, you can stop Pitocin, to Cassie's point earlier, you can't undo that you were just on Pitocin though. And once you have Pitocin, then most hospitals don't then allow you to give birth in a tub. So for me, water birth was a big goal. And if you go on Pitocin, then you're elevated into a different risk category. You can no longer give birth in the pool. If you are at a center that has a family birth center, like a birth center unit separate from the hospital, a lot of times if you start getting interventions, then they won't let you be in the birth center. You get moved over to labor and delivery unit, right? So to the cascade of interventions point, like just giving yourself time to decide, time to let your body work things out, and oftentimes it does. Labor took off naturally for me. I was able to have an unmedicated, fully natural birth without any additional medication. And so if I had said yes to that first offer, though, then that would have transitioned things totally different.
I will say nurses and doctors love times. So like you said, like 2 hours, let's do this for 2 hours. Like have that as a tool, like in your tool belt of like, if you want time to decide, give them like, if you want time to discuss something, can we have 20 minutes? Your nurse is going to be looking at the time and like marking that down, putting that in the computer, like they love times. So give them that time frame. And that goes for a lot of things with birth. Like there's a thing, we won't probably go too into like delayed cord clamping. Doctors and midwives have different ideas of what that means. Give a time. If you want to wait 10 minutes for the cord to be clamped and cut, tell them 10 minutes. That's going to be sufficient time for delayed cord clamping. But routine in most hospitals is 1 minute. So some doctors consider delayed cord clamping 1 minute. Some would consider it 10 minutes. So give them a time. They're going to be able to stick to a time better than something more subjective. Yeah.
So if somebody desires a natural childbirth and they are wanting to do so in a hospital setting, is it possible?
Oh, absolutely.
Yeah.
Absolutely. Yeah. I will say choosing your care provider, choosing your care team is probably the most important decision in helping you to achieve that, though. Being really intentional. I think I saw something not too long ago that like you should spend way more time researching your care team than you do researching your stroller. Like your baby doesn't really honestly care what stroller they're going to be in, and it's not going to affect their long-term health. What stroller they can get a $10 stroller from a garage sale, and they're not going to care. But you choosing a care team who supports your decisions is going to be probably the most important decision you can make in your pregnancy, labor, postpartum journey. So being really intentional about that, especially if your goal is to have an unmedicated birth. Do your research. If the hospital you go to has a 95% epidural rate, then look, maybe try to look elsewhere. That doesn't mean you can't have an empowering birth at that birth center or at that hospital. It just means you're going to be up against some more hurdles than you would be if you chose a care team that was a little bit more aligned with your desires.
And maybe in that case, you would choose to have a doula.
Absolutely, yes.
On your team to help advocate for you in that situation. Now, personally, I have not had a doula because I have gone through so much education myself and have been able to educate my husband on it too, that for me, it felt appropriate that I did not need another voice, but it would not hurt. But for anyone who is not a pelvic health therapist, who is not a childbirth educator themselves, have an extra voice in the room to advocate on your behalf, especially if your spouse feels squeamish about these things. Yeah. If you don't feel like they will be able to step up in that situation and be the voice for you because they are your echo and they know exactly what you want, then make sure you have another voice in the room for you.
Yes. Yeah. I would say a doula is honestly more for the husband than it is for the laboring woman. Again, like you said, if you don't think your husband is, able to really understand the medical part of birth, they understand you so well, but they don't really not have any knowledge of the actual birth and the decisions that can be made in that realm. A doula can be an invaluable resource of somebody who knows you, but really knows a ton about birth and knows what you want from your birth, and can really help you in that space to be able to make empowering choices.
Yeah, and I just think this is an important topic to discuss because in the holistic healthcare space, home birth is talked about so much. And again, this is not to say one is better than the other. It's a personal preference, but I want you to know that you can have a holistic, naturally minded birth no matter what setting you are in. Yes, if you are in the hospital setting, you are going to have to advocate for yourself more, and that is where preparation comes in. And so, with my first, I was not as well informed or well prepared, but with my second and third and now fourth, I have been. And so that I think just speaks volumes. And it's honestly why I created the Holistically Well Pregnancy Program, to give you this information ahead of time so that when you walk into labor and delivery, if that is where you choose to deliver, that you feel like you have the tools in your toolbox to advocate for yourself. Your spouse has been able to watch the videos with you. They feel well informed and educated. And you are able to be the team and the empowered decision-making team that you want to have in that birth center. And that's why Cassie does childbirth education too, because the preparation beforehand is so key. All right, let's talk about birth plans. So I've heard both sides of it. And I will say, like with my first, I mentioned not being as well informed. I was still fairly well informed, and I had a birth plan though, right? And I wrote things out to a T. I was with a midwife group, and they knew all of my preferences, and things did not all unfold that way. So with my second and third, I feel like the knowledge was all in my head, and I like knew what I wanted, if this, then that, and I had like plans A through E, you know? What are your thoughts as a labor and delivery nurse on birth plans? How is that perceived in the hospital setting? And then also your take, you know, as a doula and where you are now in your career.
Yes. So, I mean, my take on birth plans is far different than most labor and delivery nurses. Most, or at least the culture on the unit that I worked on was, you know, if somebody came in with a birth plan, the nurse would roll her eyes and say, oh, that's a ticket to the OR, you know, ticket to a C-section, you know. That is not true. That is absolutely not true. So the birth center where I had both of my sons, they required you to fill out a birth plan in order to, you know, that was part of their prenatal routine. You know, at 36 weeks, you had to submit a birth plan. It was pretty simple. It was just a checklist of like, this is what I would prefer, you know. So it wasn't anything elaborate. I didn't have to like write a 6-page long paper of like, this is my dream of how I want my birth to go. More just outline like, okay, I would prefer to give birth not on my back, or I would prefer to use the tub. For both my births, I cut the cord, which was something unique. You know, a lot of times people want like their husband to cut it. My husband was not particularly interested, but I thought it was really cool that I got to cut the cord. So just like different kind of niche things like that.
Right.
But a birth plan can be super valuable, I think, from a doula, childbirth educator standpoint. I think the biggest value of it is to help prenatally, to help with conversations and to help with research. I give out a booklet during my childbirth classes that has like a birth preferences thing in the back. But that's one of the homeworks I give to my students is to go through all these different options and discuss it between you and your husband of, okay, how do I feel about these things, or some things I don't care about, something like, I don't really care if I have an IV or not, like it doesn't make me any difference. So knowing that that's not something that's that important to you, and you can kind of brush that to the side of like, okay, we're not gonna, make a big fight about this particular thing because I'm not that concerned about it. But then being able to, okay, well, I have questions about continuous fetal monitoring. What is the policy and procedure at the place where I'm giving birth? What is their policy? And being able to discuss with your care team beforehand, like, I'm really interested in intermittent monitoring. Is that something you do at your hospital? And then being able to discuss that instead of waiting and then walking into labor and delivery and like, oh, I really wanted intermittent monitoring. And they're like, well, that's not an option here. Then you're kind of too late to be able to, again, really have that informed and empowered discussion when you're in the throes of labor. So
yeah. I think that's great. And having the conversation with your provider and your spouse ahead of time will bring up these sticking points to realize if maybe it's not aligned with the care team you're with. And that is why I think having these conversations earlier rather than later is good. I have had a number of patients who are working with me, and we've talked about I like to know from the beginning, what are your labor preferences? Are they seeking a natural childbirth versus not? And then when they tell me the care providers that they're seeing, I'm like, you might want to consider a midwife, and they will switch over and they'll switch around 20 weeks of pregnancy. But if we didn't have that conversation until 36 weeks of pregnancy, it would have been very challenging for them to switch from a OBGYN to a midwife. And the reason I do recommend midwives so often is because typically they're with you throughout the labor process, and they do not only come in to catch the baby, which an OBGYN does not come with you through laboring at all. They typically just come in when they get the call from the nurse that you're pushing and it's time to catch the baby. And I want their expertise throughout, right? And so that's why midwives are just phenomenal. Whether you're in a birth center, a hospital setting, or a home birth, if you can work with a midwife, if you are a low-risk birth, work with a midwife.
Yeah, to that point. So the way I like to think about, OBs versus midwives is that, so OBs go through all these years of medical school and residency and so much surgery experience. So OBs, they don't only do labor, birth, they do C-sections, which is an expertise that I would never even hope to be able to know how to do. But these people are, that's a really invasive surgery and they are experts at it. They also do gynecological procedures, like hysterectomies and other different surgeries. So they're really well-trained surgeons, really trained to know what to do when things are going awry, when things are not going well. Whereas a nurse midwife comes from a nurse background and then goes through a master's program typically, and their programs really focus on supporting things to go well. So both are valuable and they work really well as a team to find a group where there is, doctors who are there if things go wrong, but midwives there as your primary provider during labor, because they are trained for natural births. They're trained for vaginal births. They don't know. They're not trained to do C-sections. That's not their expertise. So really knowing that they have skills that are complementary. Yeah. And you can have an OB that's really holistically minded. You can also have a midwife who is very medically minded. So you still have to do your research there, but that's where their expertise is.
Thank you. You described that very, very well. Very, very well. So thank you. And the benefit I feel in being in a setting like a birth center or a labor and delivery unit with my first, we did have some complications during delivery where I was pushing for a really long time and they were getting concerned, and a whole team of like 20 doctors came in. My husband counted at one point there were 20 people in the room, but the midwife was like, focus on me. And my daughter came out and she was crying and she was good to go, but there was a resuscitation team in there. There was an OB with a table that if he had to do an emergency operation, he was there to do so. And so to that point, I would never have wanted the midwife to intervene for an emergency C-section, right? But the OB was there and that was his skill set if that was needed. And so just knowing, as she said, they each have their place, but ahead of time, kind of knowing how your pregnancy is progressing, what you want in your labor and delivery, and then knowing what team's going to be around you, both for if the labor's progressing well and knowing who's nearby if something were to take a turn for a more emergent situation, who would be there to step in. Okay, what are 2 to 3 things you wish every pregnant woman had learned or prepared before arriving to the hospital?
Well, yeah, I think I've mentioned this, is that definitely taking some sort of class. There's all kinds of options, in finding what works well, either an in-person class or, an online class or a hybrid, finding some variety, but doing education beforehand. But like we've talked about, really knowing that, you are in control and that really all of the options are in your hands and you are the center of your care. I guess that's really the best way to summarize that you are the center of your care team. A lot of women, when we go into a hospital, and one thing, you don't have to put on a hospital gown. It's another thing that's optional when you go into the hospital. There's this just thing that we do when we go into the hospital, especially if we end up putting on a hospital gown, that we become the patient. And we kind of think that there's this hierarchy of, patient, nurse, doctor. I felt that as a nurse, that's kind of what was where my spot was. But that's not at all, especially in labor and delivery. That's not at all what it should be or how you should feel. You are the center of your care. Anybody who is involved in your birth you should be inviting them to be there. They're being invited into this sacred space of your birth, of your child, really protecting that space, and knowing that anybody that's on your care team, that you are hiring them, they work for you, you don't work for them. Really important concept that they're not paying you to have a baby, okay? You're paying them for their expertise to help you have a safe, healthy birth. That's the desire, that's the plan. So knowing that, you are the center of your care team would probably be my biggest thing, aside from, taking a childbirth class to be able to prepare you to have that knowledge.
Okay, so post-delivery, what are your thoughts on Pitocin injections right after delivery?
So there's two different frameworks of what to do. So the reason that Pitocin would be given after birth is to help to decrease the risk of postpartum hemorrhage, which is, I think, the most common complication involved in pregnancy, birth, everything is postpartum hemorrhage. That's excessive bleeding postpartum. So in most hospitals, it's going to be routine, especially if you had an induction. Okay, if you had an induction and you were receiving Pitocin, it is absolutely necessary for your safety to have Pitocin postpartum. But if you had an unmedicated birth, you can do a thing called expectant management. It's kind of a wait and watch approach where you observe your care team will observe your bleeding postpartum. And then if there's any excessive bleeding, at that point they would give Pitocin. So for both and everybody's bodies are different. So for both of my births, unmedicated, and then, had a, delayed cord clamping for, 10, 15 minutes postpartum. And then I didn't have any excess bleeding, never had Pitocin, never had a hemorrhage, But some women, the term they would probably use in the medical world would be they have like a lazy uterus. Your uterus is not lazy. After and I don't know if anybody's done a marathon or a half marathon, after you can run for, 13, 26 miles, however long. And then if you sit down and then you try to get up afterwards, you can't even walk 2 feet. So that's how your uterus gets after birth sometimes, is that it's been working hard for, sometimes 24, 48 hours, even if it's only been 12 hours, that your uterus has been working really hard. After it pushes this baby out, sometimes it's just like I just need to take a break. But it really still has important work to do to clamp down, to stop that bleeding after your placenta is born. So I think it's an important intervention, but if you feel comfortable with it, and if you don't have a history of postpartum hemorrhage, then I think doing expectant management, which is a wait and watch approach, would be appropriate, especially if you are incorporating a calm environment that supports the release of oxytocin. So an environment where you feel safe, seen and safe, in an environment where there's not a lot of lights, not a lot of things happening, and then also an environment in which you're able to start nursing your baby and have your baby skin to skin. Super important for oxytocin release. So that Pitocin injection they would give you, either through an IV or into your muscle, it's a synthetic form of the same hormone that your body releases postpartum when you are breastfeeding, when you're having your baby skin to skin. So
love it. That was so helpful. So you mentioned a few things there. So just to give people some tangibles. So for the delayed cord clamping, do you recommend 10 minutes or until the cord has stopped pulsating? What is your typical to go off of?
Yeah. So the ideal is until the cord stops pulsating. Like I said, some doctors, midwives, they just want a number. So I would say at least 5 minutes. And then again, 10 minutes would probably be ideal, but 5 minutes, you're going to have most of the blood from the placenta and the umbilical cord has gone to the baby by that point. So I think 5 minutes is a safe. That's usually what I say in my class, is that if you're really passionate about it, 5 to 10 minutes, but give them a time.
And are you having baby against your chest throughout that?
Yep.
So
Or
getting
your
that
belly.
Skin to skin right after delivery. Yep. And then you can also ask for delayed bathing.
Yes.
Right? Mm-hmm. So what are your thoughts on that? What do you recommend communicating to your care team in a hospital setting for that?
My recommendation is to wait until you get home to bathe your baby. So I'm sure Kayla at some point will dive super deep into the microbiome, so I'm not going to go too deep down a tangent right now, but babies' microbiomes are super important, and when they're born, especially vaginally, they get introduced to your vaginal flora, which is super important for, really their lifetime of their microbiome health. So when they are washed right away in a hospital, then you wash off all those good germs, and then all the hospital germs that are just the germs that live in the hospital are then what get on your baby's skin, and then those are the germs that start to multiply and grow. So I am very supportive of waiting until you get home, and then even when you get home, you don't have to bathe your baby every day. It's like once a week. Mm-hmm. And if you want them to kind of show you how they would do a bath, and if they want to just use, water, just plain water, and kind of walk you through, okay, what does a bath look like on a baby? At some point, I would wait at least 24 hours though. And that's not only for their microbiome, that's because baby's adjusting, learning how to breathe, learning how to regulate their blood sugar, their pulse, their temperature, learning how to breastfeed. A lot of times when I would bathe babies as a postpartum nurse, and after you bathe the baby, then they just sleep for 6 hours, which sounds kind of great, but also it's really important in that initial 24 hours that they're feeding every 2 to 3 hours to start to get your milk supply revved up.
Right. Yeah, that's a great point. And so with my first, she had meconium in utero, and so that's why, the team came in and all the things, but they did not allow me to delay bathing because of that. Okay. Have you come into contact with that of if baby has meconium in utero, we have to bathe baby? That's part of our policy.
I have not heard that one.
Okay.
don't really know the rationale behind that. Because meconium is that baby's first poop. And so, but it's sterile. So unlike our poop, any poop after you are outside of the womb is not going to be sterile because you're in contact with, you're taking germs into your mouth and it's in your stool. But for a baby, that first meconium, all it is like dead blood cells or different things from the amniotic fluid that are just kind of sitting in their gut, waiting to be born, waiting to be eliminated. So I don't know that was essential. Even for some instances, like if a mom has a history of like an STD, then we will do a bath in order to, like, from a safety standpoint for the care team providing care for them, for like the nurses, so that we're not spreading HSV, gonorrhea, syphilis, any of these different STDs that we don't want to risk spreading that to anybody else, to ourselves as the medical staff or to any other babies on the unit.
So I wonder if that was a policy just because of that. Because I know even if you have tested negative, sometimes they're like, well, this is our policy across the board, because what if something changed between when you were tested and now? Like, I have heard that. So that would actually make sense. But that gives you, the listener, ability to push back, because if I had known what she just said before the birth of my first child, I would have pushed back versus being like, okay, that's what you say, But with my second and third, since that wasn't the case, then I was able to delay their baths until we got home. And then you can use your own products too. And you could even bring your own products to the hospital if for whatever reason you're like, if they say they want to do it, or I want to see how they do it or whatever, to have your own stuff there. But yes, and to our point too, like, you don't have to bathe baby every single night as is recommended, like with people who do sleep schedule stuff. They're like, you have to bathe your baby and then you do the night routine. It's like, no, there's a benefit to their microbiome, especially in those newborn days. So, okay, we've talked about Pitocin, we've talked about cervical checks, cord clamping, baths. What else are women typically presented with in a hospital setting that you want them to know is optional or something they could think about in a different way than what is usually standard policy? Anything we've missed?
Okay, let's see. We talked about cervical checks. We talked about not wearing a gown. Again, epidurals. We talked about a little bit that's definitely optional. Trying to think. I don't know that there's a ton else that was. It's just movement. So really, embracing movement and I guess birth. The birth positions would probably be, I guess, the one thing. You can give birth in whatever position feels right to you. In the movies, and we see people on their back with their legs up in stirrups. And again, I'm sure Kayla will get into this deeper in a different episode about birth positions. But you may absolutely give birth in whatever position feels best for you. Even if your care team makes you feel like it's not an option, it totally is an option. The unit I worked on was very, I think probably about 95% of people got epidurals. Most gave birth on their backs. It was fun as me and a couple other nurses that were a bit more holistically minded tried to kind of change the tide. That some of the OBs started to become a bit more open to women giving birth, on their side, or at least with the tilt, or on their hands and knees. So all good positions. But yeah, I not only is it an option, it's really beneficial to be able to have that movement opportunity to be able to give birth to your baby.
Yeah, and that's why we talk about intermittent monitoring, the benefits of that, or a Bluetooth monitoring device, something like that allows you to move, because that is going to make pain management so much easier during labor, help baby get into optimal position, and then to birth in the position that just you intuitively feel like going into, whether that's hands and knees, standing, squatting, in the throne position, because the bed can be manipulated oftentimes where you're like in a seated position, but like on a squat on the edge of the table. So we will definitely deep dive into all of that in a future episode, and that is something I cover in detail in my birth prep course as well. Something else that brought to mind would be pain management. Yeah. So epidural is obviously something you can decline in that birth plan preferences. You can say, I do not want an epidural. Please do not offer me one unless I bring it up. That is something that I know a lot of women will do, because sometimes it can be beneficial and needed, but you don't want people telling you that it's needed and making you feel like it's needed. That needs to come from you, right? What else would you say from a pain management standpoint?
And you're gonna have to talk to your care team about their ability to have to give birth in the tub, but almost every labor and delivery unit is going to have an individual shower in each room. So knowing that that's typically an option if you really like water. So that's like a more holistic standpoint. And then again, movement's gonna be great. Most hospitals are gonna have heat packs, ice packs or heat packs that you can use, or bring your own from home. Those are the big things there. But then as far as medical options, so you also have the option of IV pain medication. A lot of women don't know that. So you have the epidural, and most people know all about that, but there's IV pain medications, so they include Stadol, morphine, some of those narcotics, which there's some downfalls to those. So epidurals, there's not as much medication that actually gets into the baby's system. Most of it's just staying in your system as the mom. But with any sort of IV medication, it's going to basically go straight into the baby's system. The same level that's in your blood is going to be in the baby's blood, which we really want to avoid, any time within a few hours before baby's born, because it can depress their drive to breathe, which is the single most important thing they need to do right after they're born is start to take those breaths. So if they have any sort of pain medication, IV pain medication that's in their system, it's just going to decrease that drive to breathe. So those can be helpful. Typically, from my experience as a nurse, they're not typically they don't work as effectively, and I feel like they honestly have more downfalls than an epidural. The biggest benefit is that it wears off, and then you can go back to moving around. So if you had a really long labor and all you need is like a 30-minute nap, that can be helpful. But other than that, those IV pain medications are not ideal.
Okay.
So those are the biggest things for pain management from the hospital standpoint.
Yeah, from the hospital standpoint that you might be offered. And we'll definitely, again, future episode topic, we'll fully deep dive into natural pain management strategies. One other thing that brought to mind was food. Eating during labor. So that can be a common policy that they'll tell you no food, just ice chips. Can you tell us why that is from a hospital standpoint, and also what you can actually do? Yes,
please eat food. Anyways, but from a hospital standpoint, again, from when you're the nurse, you get these orders from the doctor that are sometimes after a woman is in active labor, she's NPO, which means nothing by mouth, which means that she's not supposed to eat or drink anything but like ice chips, which is not nourishing. Okay, that's not nourishing. It's barely even hydrating. The reason that is on the rare chance that you would need an emergency C-section, there is the chance that you would need to be intubated. So you need to be, need general anesthesia, which is when they put you to sleep, and then they need to intubate you, so put a tube down your throat. During that process, there is the possibility that you throw up, that you vomit, and then you aspirate that, which means to breathe it into your lungs. And if that happens, there is a possibility that you could have some sort of infection or some sort of issues in your lungs afterwards. It's like pneumonia afterwards. There were lots of ifs in there. Lots of ifs. And honestly, a C-section is more likely if you're not able to nourish your body during your labor. Your uterus I've kind of made the comparison to like a marathon or a half marathon. Your uterus is, literally, working out for the entirety of your labor. So if you're in labor for 24 hours, your uterus is working super hard. Your uterus is a muscle and it needs fuel. Yeah. So it needs, it needs proteins, carbohydrates, fats, it needs electrolytes, it needs all those things to be able to function properly. If you tried to run a marathon without eating or drinking anything, you're gonna get depleted. So same thing during labor. If you're not fueling your body, and you're not gonna probably want to eat a steak dinner when you're in labor, and that's okay. But having some nourishing snacks throughout labor is super important, and hydrating with something like Element or some other sort of electrolyte sort of substance to be able to nourish your body is super important for labor progress. And it's honestly some of the reasons that some women have a stalled labor is that their body just needs fuel.
Yes. So the evidence really points to that the benefits outweigh the risks. And that is something you always want to ask. What are the benefits versus the risk? And evidence strongly points towards benefits outweigh the risk when it comes to eating during labor. And as she said, your body's going to naturally tell you that it doesn't want a huge, heavy steak dinner. But you may want some bone broth that's going to give you some nice protein and just warmth and good micronutrients. Protein bar, elements, you're getting some electrolytes. Soup, I had chicken noodle soup whenever I was in labor with one of mine. So nourishing, but also some lighter foods are probably going to sit best with you. And this is where many hospitals are updating their policies. Where I most recently gave birth, receptionist, when my husband came back upstairs with some food, he had stepped out to grab me some chicken noodle soup and some sourdough bread and bone broth. And when he came up with that bag, the receptionist said, whoa, 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 why are you bringing food back there? And he was like, it's for my wife. And she said, she's not allowed to eat in labor. And what's hilarious is my husband the nurse had just encouraged him to go out and get some food for me, and the midwife too. So our care team, the nurse and the midwife, were 100% encouraging of me eating, but the receptionist was trying to stop him from bringing food back to me. So that was just an old policy that she wasn't aware had been updated. So even if you get some pushback, make sure you advocate for yourself, you're informed ahead of time, which you are because you're listening to this episode, and then know that not everybody who you're interacting with may be as well informed as you. And so to just take that with a grain of salt and know you are totally fine to proceed as you had planned.
And you can always, again, I mean, this is a way that you kind of get like around some of the policies, is that you can always, if there's something that you really want, like eating, which again should not be against any sort of policy, but if that is, the hospital's policy that you can't eat or drink, then, when you have a conversation with either your nurse or your doctor or your midwife, and you say, well, what are the risks of this? And then they can tell you the risks, and then you can say, I understand the risks, I'm still going to go ahead and eat and drink. And then they can document that in the computer so that they're covering any sort of legal thing that they think that they will be liable for. If they can document that patient educated about risks and wants to proceed with eating and drinking or a whole variety of different things, then they can document that, and you can go and you can choose whatever you want to choose.
Perfect. Well, I think that was a great way to summarize today's conversation of ultimately the choice is yours, but it's so important to understand the benefits and the risk associated with any choice that you make, but to understand that you have options. You can give yourself a little bit of time to decide, and then always ask, what happens if I do nothing, or if we choose this instead of that? And so I hope that from today's conversation, you are reminded that you have these options and your birth matters, and creating the type of birth that you want is possible no matter what setting you are delivering in. So Cassie, where can people find you? Where can they work with you if they would like to learn more?
Yes, so I am on Instagram at Womb by Cassie, and then again my website is also Womb by Cassie, some variety of that. Just Google Womb by Cassie, and I think that's about it. Those are my things. And again, I offer in-person childbirth classes for sales. So if anybody's interested in that, or if anybody's just interested in like a one-on-one, 30-minute chat through like a birth plan and kind of talking through that, that's something I offer as well. So
awesome. So if you are local to the area, definitely check out Cassie's childbirth program. And if you are anywhere worldwide, I do have my Holistically Well pregnancy program that I would like to personally invite you to, because as we said, the preparation that you do ahead of time truly matters. So inside the program, we dive deep into preparing your body for birth, but also your mind and your nervous system, and helping you feel strong, confident, and grounded in your decision-making skills as you deliver. So I am so grateful to Cassie, who is a doula and a past labor and delivery nurse, and now studying to be a nurse practitioner. So she brings a wealth of knowledge in this space, and it was so awesome to have her on the show today. So until next time, take care and be well. Hold on a second. Don't go just yet. I've got a special giveaway just for my Holistically Well listeners. Each month, I'll be choosing one winner to receive a free one-on-one session with me, Dr. Kayla. That's a full 60 minutes, virtually or in person, focused entirely on your individualized care with a holistic doctor of physical therapy. To enter, just hit pause, leave a 5-star rating, and share what you're loving about the show. Your feedback helps shape future episodes and helps more women find this space. I can't wait to connect with you.